Hello students, welcome to this ophthalmology recall session of the NEET PG 2023. Now, before I go on to the questions, I would like to begin by saying two things. One is that these questions have been recalled from memory by students who have taken the exam. So some of the options may be missing in a few questions. Some of the options may not be exactly what came in the exam. And also the wording of the question or the way the question was presented may be a little different from what it actually was. But the basic essence of the question is what we are going to discuss here in this session. Secondly, I want to say that who are the people who should actually watch this session? I would say that those of you who have given the exam, it's better if you just relax for the next few weeks without bothering about what actually came, whether you got it right or whether you got it wrong, because you have done a lot of hard work and it's time for you to relax. But this session, I would say, is actually important for those of you who are planning to take the exam the next year. Because this year's question pattern, according to me, was largely clinical. It focused on important and common clinical conditions, important clinical conditions that we would encounter in practice. And what we needed to do in the exam was actually very similar to what we would do in our OPD. Like when we get a patient, we get the signs and the symptoms, and we try to figure out what the patient actually has, try to eliminate between conditions, think of differentials. The exam was very similar to that. There were clinical questions. The questions were not on uncommon clinical entities which are written in the footnotes of textbooks. No, it was on important commonly encountered clinical conditions. So it kind of tells us that we should focus on these topics for the exam. Also, this session will try to tell you how to prepare a particular topic in ophthal, because we have to understand that we have to learn everything from a clinical bent of mind, because that is what is being asked, right? So with that, let us start with these questions. So let us look at this first question. A patient presents with inability to see on the right side, or the wording might have been the right halves of both eyes, and what is the possible site of the lesion? So let's look at what this question actually means. It says that the patient is not able to see on the right side, right? So, or as you can put it, on the right halves of both the eyes. So right halves of both the eyes means the nasal part of the left eye and the temporal part of the right eye, correct? So the nasal part of my left eye and the temporal part of my right eye, these are the right halves of both the eyes. So now if I were to draw an image like this, suppose I draw something like this. What do I mean exactly when I say right halves of both the eyes? This is the right eye, this is the left eye. So this is going to be something like this. The nasal part of the left eye and the temporal part of the right eye, the patient is not able to see. This is nasal, this is temporal, this is nasal, this is temporal. So the nasal part of the left eye and the temporal part of the right eye are affected. So what do we call this? We are going to call this as a homonymous hemianopia. This is what? This is a homonymous hemianopia. To be a little more precise, we would call it as a right homonymous hemianopia, because it is on my right hand side. The right halves of both the eyes, or we should say the nasal half of the left eye and the temporal half of the right eye are affected. So this is a right homonymous hemianopia. So when you have a right homonymous hemianopia, the site of lesion is your left optic tract. So what is the size of the site of the lesion? It is the left optic tract. Okay, now always students tend to confuse this with optic chiasma. So just have a look at these two images. So see, the first one is what we were discussing. If this is right and this is left, see the nasal half of the left eye and the temporal half of the right eye are affected. So this is the homonymous hemianopia which came in the question. Now this one here, if you look at the image below, this is where students get confused. Now here see the lateral halves of both the eyes or the temporal halves of both the eyes are affected. So this is a bitemporal hemianopia. So the second one here that we have drawn, this second image, this is a bitemporal hemianopia. So there is a difference between these two, and you all know that bitemporal hemianopia, the site of the lesion is what? The site of the lesion is your optic chiasma. So here for this it is optic chiasma. And for the other one, that is the one that came in the question, this is your optic tract. And we have to remember that if it is on the if the blackening or the loss of vision is on the right hand side, we will call it as a right homonymous hemianopia, and therefore the site of the lesion will be the left optic tract. So see, if this is how the question is given, then we understand that this is a right homonymous hemianopia. If it had been a chiasma, what would they have said? They would have said that there is a lot of loss of vision on the lateral halves of both the eyes or the temporal halves of both the eyes. Right? For optic nerve, what would they have said? They would say that there is a loss of vision in the right eye. They would not say right side, or they would not say right halves of both the eyes. So for right optic nerve, the question would have said there is a loss of vision in the right eye. For optic chiasma, they would have said that there is a loss of vision on the lateral side of both eyes, or lateral halves or temporal halves of both eyes. Okay, so as I have been saying, this session I would say is more meant for students who are actually going for the exam next year. So this is how you have to approach these topics. That is, if you learn the visual pathway, try to think how the question can be worded also. Like this is how it can be worded, and also try and look at the images, because this time they have not given the image. Next time they can give the image. They can give this kind of an image and they can ask what is the site of the lesion. Then also we should be able to answer the question. And see, this is also something we do in clinical practice. We get patients with pituitary adenoma, we do a perimetry for them, we see this kind of a bitemporal hemianopia. You can get patients who have CNS lesion, vascular infarcts in the brain, who come to us with this kind of a homonymous hemianopia, etc. Okay, so this is sort of a repeat question, has been asked many times in different ways. Okay, so this tells us that one topic that is very important to prepare for whatever exam is the visual pathway. So let me go to the next question now. This is also again a very commonly asked question. A patient is brought to us with watering, photophobia and blepharospasm. Now I'm not sure whether all these three words were given in the question, but the clinical photograph was given. So see, this is the triad of symptoms. Like, what is the triad of symptoms in congenital glaucoma? All of you would have understood that the answer to this is congenital glaucoma. So the triad of symptoms is lacrimation, that is watering, photophobia and blepharospasm. Sometimes in the question they mention the whole triad, sometimes they don't mention the triad, they will mention one or two things. But they will always say that it's a baby, it's an infant, and this kind of a photograph is given. What do you see here? You see large eyes and the cornea is extremely hazy, giving almost a bluish appearance. So this is what is ophthalmos. Now, this is the most striking clinical sign of congenital glaucoma. So, in adults in glaucoma, the size of the globe is not going to change if there is an increase in pressure, but in the child, the size of the globe enlarges. You get this hazy, large, hazy cornea, this bluish appearance. This is called as ophthalmos. So, the answer is congenital glaucoma. This also has been asked many times in different ways in different exams. Right? Now see, the only other condition which gives you a hazy cornea is this, that is mucopolysaccharidosis also gives you a hazy cornea, but then those patients will not have this kind of a large eyeball. So large eyeball with hazy cornea will not be there. The cornea will be hazy in mucopolysaccharidosis. It is one of the causes of hazy cornea in a child, but the other features will not be there. And cataract and ophthalmia neonatorum obviously don't have this kind of presentation, right? Cataract, the presentation will be with leukocoria, and ophthalmia neonatorum, the patient is going to present with stickiness, discharge, redness, etc. etc. So this is another important topic. So they have given us the triad. Either they give us the triad or they give one or two things of the triad: watering, photophobia and blepharospasm, and these kind of large eyes with hazy cornea, bluish appearance, that is ophthalmos. Okay, so this was our second question. Now let's go to the third question. Now the third question, there is a lot to learn from this question. So this is fairly what the question was like, that a 65-year-old diabetic patient presents with gradually progressive decrease in vision, and we are given a slit lamp photo and we are asked what is the diagnosis and what is the management, right? Now The options are C, snowflake cataract with ECC with aphakic glasses, immature cataract, phaco with IOL, rosette cataract, glycemic control, zonular cataract, lensectomy. Now, I'm not sure whether these are the exact options, but the options are very similar to this. Now, I'll tell you what are the things that students are likely to get confused when they get this kind of a question. So see, this question is talking about an elderly patient. It's talking about an elderly patient, and they have mentioned this word diabetic, right? Now when they mention this kind of a word diabetic, then automatically there is a tendency to think about the metabolic cataracts. So the students, they may be tempted to mark this kind of an option, that is snowflake cataract, if it is there in the option. But see, snowflake cataract is not the commonest type of cataract which is seen in diabetics. It is not the most common type of cataract. It's kind of a specific looking cataract, and the picture that is given to us, this is not a snowflake cataract. This is a regular cataract that is seen in elderly people. And we also understand that in elderly people who are diabetics, the progression of cataract tends to be faster, and that is why this word diabetic was mentioned. An elderly diabetic patient is likely to have a faster progression of a cataract. So, and gradually progressive decrease in vision, and you see this is an immature cataract, a regular cataract which is seen in elderly people, progressing faster because the patient is a diabetic. And what is the treatment, the accepted treatment, modern day treatment for cataract? It is phaco with IOL. So this is our answer. Now even if you get confused when you look at this option snowflake cataract, look at the rest of it. It says ECC with aphakic glasses. Are we doing ECC today? Not if we can avoid it. Only in very small centers where we don't have a phaco machine, we might be doing ECC, but we will not leave a patient aphakic today. Today we will always go for PCIOL implantation. So this aphakia is something which we will not do. So that is why that option gets excluded. Okay, and of course the other two, rosette cataract, we all know this is seen in trauma. And only glycemic control anyway is not going to improve the vision of the patient. So if a patient has cataract, of course you have to do a glycemic control, but that we have to go for the surgery if we want to improve the vision. And zonular cataract, this is a type of congenital cataract. This is a type of congenital cataract, so obviously this cannot be the option. So the answer to this question is that it is an immature cataract, and the treatment for this patient is phaco with IOL. Okay, so once again, we have to look at common clinical entities. An elderly patient coming to us with a cataract is likely to be a senile cataract. That's an immature cataract, an immature senile cataract, and we have to offer him a phaco with IOL implantation. The diabetic is meant probably to confuse, but we have to understand that snowflake cataract is more likely to be in younger patients, and it is not the most common type of cataract that is seen in diabetics. Okay, so this is the third question. Now just to have a look at the other types, so don't get confused. This also is, as I told you, I want this session to be more for students who are preparing for next year's exam. So this tells you to think of common clinical conditions. It also tells you learn to identify the common clinical images. So see, this is a zonular cataract. This all of you will know, this is a rosette cataract. This is the rosette cataract which is associated with blunt trauma. This is the rosette cataract associated with blunt trauma. And this is the sunflower cataract which you get to see in Wilson's disease. So these are like characteristic images, and it is better if we know how to identify these characteristic images, because that also then helps us in the process of eliminating things in the exam. Okay, let's go to the next question. Now this also is again a very, very, very relevant clinical question. An elderly patient presents with difficulty in distance vision, but he does not need to use glasses for near. And this is our slit lamp photograph. So see, what is it talking about? The distance vision is not good and the near vision is good. So this is some form of myopia, right? Now see, the commonest type of myopia we all know is axial myopia. But see, the patient is an elderly patient. Where will I get to see axial myopia? I'm going to see it in children who are growing up, children of second standard, third standard, who are in the growing stage. And then when they get that axial myopia, they come to us with this complaint that the distance vision is not good. But here it's an elderly patient who has come to us, and look at the picture. This is showing us a cataract. So what kind of cataract is this? This is typically a nuclear cataract. And when you have a nuclear cataract, what happens? There is an increase in density of the lens nucleus. There is an increase in the refractive index. And this change in refractive index is producing this myopic shift in refraction. So this myopic shift in refraction is because of a change in this refractive index, and that is why we are going to call this as index myopia. So this is index myopia, which is associated with nuclear cataract. Okay, so important is that this is telling us about nuclear cataract, a very, very common thing that we encounter in clinical practice, and what they are mentioning is nothing but the second sight of old age. So this is something, if you sit in the Ophthal OPD, you will be seeing almost every day. So this is a very common clinical condition. Old people coming to us and saying that I am not able to see well for distance, but I am able to read much better than what I used to last year. I have stopped using my reading glasses. I can read the newspaper without my glasses. I don't need my mobile. I don't need my glasses for looking at the mobile, but I'm not able to see the TV. So this is the common condition, nuclear cataract, which is seen in elderly people, and you will see this kind of an opacity in the central part of the lens, which is suggestive of a nuclear sclerosis. Right? So this was our next question. Next. A patient presents with jaundice, tremors, and a golden brown ring on the cornea. So this golden brown ring on the cornea, concentric to the limbus or close to the limbus, this was there in the question. I am not very sure whether jaundice and tremors was mentioned in the question, but if you look at the option, it is iron, ceruloplasmin, alpha fetoprotein, alpha 1 antitrypsin. Something very similar to this was given. So where do you see a golden brown ring on the limbus, very concentric to the limbus? The first thing that comes to mind is this is the KF ring, and this is seen in Wilson's disease, where there is a deposition of copper, and therefore we have to check for serum ceruloplasmin. So serum ceruloplasmin is the answer. So commonly when they give this question, they do mention that this is a patient who has jaundice, some neurological manifestations like tremor. And then only, because that is how these patients are, they generally present to the medicine OPD with the complaint that the child has got tremors, or the child has got incoordination, and there is obviously jaundice. And when they examine, and if the clinician thinks that there is a likelihood of Wilson's, then they are often sent to the Ophthal OPD to look for the KF ring. And then this is what the KF ring looks like. It's like a brownish or a golden brown ring which is close to the limbus, and if it is present, then that kind of confirms the diagnosis. Then we can say that it is Wilson. Of course, we still have to do the investigation for a final confirmation, but clinically when they are sent from the medicine OPD, children with tremor, neurological signs and symptoms and signs also, like tremors, and when we look at this KF ring, it kind of confirms the diagnosis of Wilson. So this is another question. This is the next question that had come. So I don't know whether jaundice and tremors was there, but ideally if they mention it, makes the process of diagnosis much easier. Okay, so this was the next question. Let's go to the next one. Now, this image represents different types of what? So, the options are myopia, hypermetropia, astigmatism, and presbyopia. So, first of all, what is this image? This image is the Sturm's conoid. And what does the Sturm's conoid show us? The Sturm's conoid shows us the different types of regular astigmatism. It shows us the different types of regular astigmatism. Now, some students said that this CDE, it was circled out and we were asked what this represents. Actually, not just CDE, all these points, that is A, B, C, D, E, F and G, they represent the different types of regular astigmatism. Like for example, it represents simple hypermetropic astigmatism, compound hypermetropic astigmatism, mixed astigmatism, simple myopic astigmatism and compound myopic astigmatism. So each of these sections actually means one of these. Like for example, this point, that is point A, this represents a compound hypermetropic astigmatism. Similarly, the point C, D and E, they represent mixed astigmatism. So these points actually, each of the this is one topic I think that for in the coming exams, astigmatism and refraction is something which we will need to do in much more detail if we are expecting more clinical questions in ophthalmology. And also the weightage of ophthalmology is going to increase in the coming exams, then we have to expect more questions from refraction, and we have to do it very, very well. We have to understand the optics of the eye, we have to learn about the different types of refractive errors, and we also have to learn about glass prescription. So the process has started, I think, with Sturm's conoid, because lots of questions are possible from here, and refraction is the backbone of ophthalmology. So if we have to ask more questions from ophthal, there is bound to be questions from refraction. So see, there is this terms conoid. The question that came this time is simple. They are just asking us what is this showing. So this is actually showing the different types of regular astigmatism. But what we should learn is, we should learn that if the retina is at the point A, what is the possible refractive error? If the retina is at the point B, what is the possible refractive error? Those are the things we have to learn. What is the interval of Sturm? What is its importance? And we also have to learn we have to learn the images of the different types of refractive errors. So that is what this question kind of is a precursor of many similar questions to come. Okay, so this is the answer to this question, that is astigmatism, right? So shall we go to the next one? Next, this was a completely image-based question. What is the diagnosis from this image? Is it a pterygium, or is it a pinguicula? Is it a dermoid or lipodermoid? So see, those of you who have been looking at image-based questions, I think two options everybody was able to exclude, that is pterygium and pinguicula. They don't look like this. The confusion was between dermoid and lipodermoid. So this is, if this was the image that came in the exam, then this is a limbal dermoid. This is a limbal dermoid, a dermoid arising from the limbus. And when we see limbal dermoid, the syndrome that we have to keep in mind is golden hair syndrome. Not that every limbal dermoid is golden hair, but this is one thing that we keep in mind when we see a limbal dermoid. Now, there was a lot of confusion as to whether the picture given was dermoid or lipodermoid. Now see, I'll just tell you, this is the image that most of the students voted for. So that's why I'm saying dermoid is the answer, because lipodermoid is not like this. Limbal dermoid it's close to the limbus. Lipodermoid is more towards the canthus. This is what a lipodermoid looks like. This is a very typical image of a lipodermoid. So you see this mass close to the outer canthus. This is what a lipodermoid looks like. So if this was the image that came in the exam, then it is lipodermoid. But if this is the image that came in the exam, that is this kind of a well circumscribed mass which is close to the limbus, half on the cornea, half on the other side, then this is a limbal dermoid. This is something we see in practice. And whenever we see this in practice, as I told you, we have to keep the golden heart syndrome in mind. Okay, let me go to the next question. Now, this is also another question where I do not know whether these were the options that were given, but I'll tell you what to learn from this question. So see, the question that was given is, from this image, identify what is the stain used and what is the filter. Now, the answer to this is that it is the fluorescein stain and the cobalt blue filter. So this is a question about the vital dyes that we use in ophthal. And if you have been to the ophthal OPD, you would know that the commonest dye that we use, that is the fluorescein. You have seen it is usually we have these orange strips which we use, and we use this stains the areas of epithelial erosion. So when you expect a corneal abrasion, you expect a corneal ulcer, then you can use this dye to stain it. That is, if there is an epithelial defect on the cornea, then you can use it to stain, we use it to stain the cornea. So this is what it looks like, and you always, whenever we use the fluorescein stain, we put on the cobalt blue filter. So I think either of these two images was given in the exam. The first one is a dendritic ulcer, which we commonly see in herpes simplex HSV, herpes simplex virus keratitis. So you will have this kind of a linear ulcer, and then you will have branches like this. So this is what we typically call a dendritic ulcer, and it is usually like very small and slender, and sometimes it's not visible until and unless you stain it. And in the later stages, if it is not treated, then it is going to become like this, a kind of shapeless ulcer, which we call as a geographic ulcer. So this is the fluorescein dye. You would have seen that fluorescein dye, we use it not only for this, you can use it for staining as I said, any kind of epithelial erosion, which can be a punctate keratitis, it can be this kind of a dendritic ulcer, a geographic ulcer, it can be an epithelial defect post-trauma. But apart from that, you have seen the same thing being used in applanation tonometry, and those are images you have to know. We use it for staining the tear film prior to doing an applanation tonometry. Fluorescein is also used in fundus fluorescein angiography. So these are the other uses of the fluorescein dye in ophthalmology. Now see the question about the other option, that is lysamine. Now lysamine is also used for staining the dead and we should say the degenerated epithelial cells, and it also stains the mucous strands, and we often use it for diagnosis of dry eye, right? But more commonly, lysamine green is used for conjunctival staining. So it looks something like this. It is more commonly used, I would say, for conjunctival staining. So this is ocular surface disorders. It is used for staining the conjunctiva. So this is what your lysamine green looks like. And here we don't usually use any filter. There is no background, the background is white only, na? So lysamine green, this is what the image commonly looks like, whereas in case of fluorescein, you will see that the background is blue because we examine it under the cobalt blue light of the slit lamp. So that is the answer here, fluorescein stain and cobalt blue filter. So again, what is the takeaway from this particular question for those of you who want to appear next year? You have to learn about the vital dyes. Learn where they are used. Where is fluorescein dye used? What are its uses? What is the what light does it absorb? What does it emit? And then learn about the images of fundus fluorescein angiography. Learn about the other vital stains like lysamine green. Where is it used? Rose Bengal. Where is it used? Which is more commonly used? Why Rose Bengal is not commonly used? So learn up these important points about these vital dyes. So this is also something that you do in OPD. Fluorescein, you will see if you go to the OPD, you will see this stain being used. So that's why this was given. Lysamine is not that commonly used. I won't say it's not commonly used, but fluorescein is something which we use every day. So a very common clinical thing has been given. So learn up about the vital dyes. Okay, let's go to the next question. So this question is again whether we should call it a biochemistry question or an ophthalm question. A child is brought with complaint of mental retardation, muscle weakness, there is no hepatosplenomegaly, and there is a bilateral cherry red spot. So among the ophthalmic causes of cherry red spot, we have the central retinal artery occlusion and we have Berlin's edema, which is post-trauma, and these are the other causes, right? So now, cherry red spot is there, but apart from this, among the other features that are given like mental retardation and muscle weakness, they are present in varying amounts in all these conditions. But what I think is the differentiating factor is the absence of hepatosplenomegaly. So this no organomegaly or no hepatosplenomegaly, I don't know exactly the word that was given in the question, but the students essentially were able to recall that it was mentioned that hepatosplenomegaly or organomegaly was absent. And because hepatosplenomegaly was absent, that's why I think the answer to this question should be Tay-Sachs disease. because Tay-Sachs disease is one where you don't have hepatosplenomegaly. In the others, that is Niemann-Pick's disease, Hurler's disease, Gaucher's disease, in all of them, hepatosplenomegaly is going to be present, right? And also in Hurler, we tend to have a hazy cornea. So the hazy cornea or the cloudy cornea is the more representative ophthalmic finding in case of a Hurler syndrome as compared to a cherry red spot in the cornea. So if you look at it from an ophthal point of view, a Hurler syndrome patient, we would rather say that the child has presented with a bilaterally hazy cornea rather than saying that anything about the fundus. For the others, of course, the fundus is important, but when hepatosplenomegaly is absent, we have to choose Tay-Sachs as the option. In the others, hepatosplenomegaly or organomegaly is likely to be present. Okay, so this is another question. And the last one. Now, this is one question where students had a lot of difficulty in recalling. So the question was something like this, that what is the most common complication that you would associate with a given condition? Now, it is, I do not know whether it is picture number 1 that was given or picture number 2 that was given in the exam, because students essentially recalled saying that there one side of the face was black. Now picture 1 and picture 2 are not the same thing. Picture number 1, which I feel is probably what was given, this is oculodermal melanosis. This is oculodermal melanosis. I am not sure, but I think that if this is what was given, this is called as nevus of Ota. This is nevus of Ota. So you can see that this is a melanosis, the skin over the eyelids and almost this part of the face, that is usually that has this kind of a blackish discoloration, and you can see the same in the episclera. So look at the episclera. You will have these kind of melanosis, episcleral melanosis, and also melanosis in the skin that is surrounding the eyelids and this half of the face. So this is called as oculodermal melanosis or nevus of Ota, which has a very strong association with glaucoma. So students were able to recall that glaucoma was one of the options, and that is what kind of led me to think that the picture may have been oculodermal melanosis or nevus of Ota, in which case the answer is glaucoma. But suppose the picture was this. Now if you look at this picture, now this is not oculodermal melanosis. This is a congenital melanocytic nevus. This is a congenital melanocytic nevus. So for a congenital melanocytic nevus, if this is the picture that has come in the exam, then the answer probably is going to be malignant melanoma. So if you, depending on what is the picture that has come, the answer is likely to change. So if it is a congenital melanocytic nevus, then we would probably consider marking malignant melanoma. But if it is an oculodermal melanosis, which I think is more common clinically, that is nevus of Ota, that has got a very strong association with glaucoma, and then we should mark a glaucoma as the answer. So this question had a lot of confusion because students were not able to recall it that well, because the image is also not something which commonly you see in practice, or you would have seen even in your questions. So these are the questions that we had from Ophthal. So before I end this session, as I told you, this session I primarily wanted to do for students who are preparing for next year's exam. Those who have already done this year's exam, relax and just wait for the results, and don't go about listening and trying to analyze what are your mistakes. It's only going to add to the stress. But the idea of this session was, as I told you, to tell you what are the topics that you need to study, what kind of questions can you expect if we are expecting a clinical question paper next year, and what is the depth in which we need to study these topics. Okay, so thank you very much for being a part of the session, and I hope that this has given you some insights into the nature of ophthal questions. Thank you.